Hello, everyone. It's my pleasure to be here with Dr. Gregg. I'm Karol, one of the first-year cardiology fellows at the Mayo Clinic. Dr. Gregg is one of the interventional cardiologists that has shaped our career and our clinical practice, so it's truly my honor to be with you here, Dr. Stone. Thank you for taking the time. We are going to discuss the findings of the ultimate DAPT trial.
Well, my pleasure. Thank you. So we presented at the ACC this year the ultimate DAPT trial and published it simultaneously in the Lancet. And we wanted to test really what the optimal duration of dual antiplatelet therapy was in patients who presented with an acute coronary syndrome, either unstable angina, non-STEMI, or STEMI, the highest risk patients that we actually treat with PCI. And if they have a successful PCI with a contemporary drug-eluting stent, we put them on dual antiplatelet therapy now, ideally with a potent P2Y12 inhibitor plus low-dose aspirin. And the current guidelines say continue that for a year. But there have been many studies that have been looking to try to shorten that duration, first to 6 months, then to 3 months, and maybe even to 1 month. And to try to discontinue the aspirin, which seems to principally cause bleeding, but we're not sure if it actually provides a lot of anti-ischemic effectiveness. And other studies have gone as short as 1 month in patients who were maintained on ticagrelor, but those were open label trials and they weren't adequately powered to look separately at whether there was a reduction in bleeding and whether there was non-inferior findings in terms of ischemic MACE. So the ultimate DAPT trial, we took 3,400 patients that were enrolled in China, Pakistan, the UK, and Italy. And they all presented with an ACS, with about 60% having a recent STEMI or non-STEMI, and 40% having unstable angina, but with EKG changes, and often thrombotic lesions. And they were treated with PCI. They were kept on open label ticagrelor and aspirin, and these 3,400 patients did well for 1 month without major ischemic events, bleeding events, side effects from ticagrelor or the aspirin, et cetera. And then at 1 month, we randomized them to stay on the ticagrelor and either gave them aspirin study drug or matching placebo study drug. And then we followed them from 1 month to 12 months. And what we found was that indeed, by discontinuing the aspirin, the rate of bleeding was decreased by about 55%. And it was minor bleeding as well as major bleeding. Major bleeding was reduced by about 60%. And actually, there were 4 fatal deaths in the ticagrelor plus aspirin group and only 1 fatal death in the ticagrelor alone group. So then the question really was, well, was this a safe thing to do? Did we not increase the rate of adverse ischemic events? And fortunately, we saw almost identical rates between 1 and 12 months of major adverse cardiovascular or cerebrovascular events. It's 3.7% with ticagrelor plus aspirin and 3.6% with ticagrelor alone. And the 95% confidence interval was quite tight around that hazard ratio of almost 1.0. So after the ultimate DAPT trial, we can really safely conclude that at least in most patients, if not almost all patients, acute coronary syndrome, regardless of unstable angina, non-STEMI or STEMI, treated with contemporary drug-eluting stents, which of course are much safer and protective against ischemic events than the first generation were in the past, who get through the first month on dual antiplatelet therapy with ticagrelor plus aspirin, that at that point we can safely discontinue the aspirin. They don't need the aspirin to protect them from future MI or stent thrombosis. And by doing so, you'll really prevent a lot of major bleeds that are very important to patients.
Indeed, it's one of the most groundbreaking trials that we have been seeing in the ACC 2024. Thank you, Dr. Stone. So would you say that the applicability of the trial can be generalized as soon as it's published? I just saw it 2 hours ago in the Lancet. It's published.
Right. Well, I do believe so, because this is not the first trial of its type. And like I said, it builds on other studies like the placebo-controlled Twilight study that stopped stopped aspirin at 3 months. And then there were other studies, including Global Leaders, TICO, and TPAS that stopped the aspirin at about 1 month, although those studies were open label and not placebo-controlled and had limitations. So now we've got this big placebo-controlled trial, which really, I think, should be the last word. And I do think this is generalizable. The questions that remain, the major question that remains is, would it do just as well if the patients were on aspirin plus prasugrel? Prasugrel is the other potent P2Y12 inhibitor. If you maintain the patient on just Prasugrel from 1 month to 12 months, would you get the similar type results? I would suspect you would, but that really hasn't been studied. And then, what about clopidogrel? Clopidogrel, I don't think you can assume, because clopidogrel is much less potent. And after an ACS, that may or may not have adequate potency, especially because there are some people that don't metabolize the clopidogrel drug. So I do think these results are pretty generalizable right away, even before guidelines change. And then I hope they will change the guidelines.
Excited for the high-risk bleeding patients that present with ACS or non-ACS, actually. Right. What will be the major limitations of this trial, Dr. Stone?
Yeah. So there are not that many major limitations. I mean, when you really look at them carefully, I think the major limitation that most people would wonder is that about 88% of the patients were from China in the trial. And, Asian patients have difficulty metabolizing clopidogrel. And so we have to question clopidogrel studies. Is their relationship, do they apply when you look at a US or Western European population? But ticagrelor and prasugrel, there's not that issue. And so I would think that studies of ticagrelor and prasugrel from Asia are generalizable. And this study was done with a very high quality, very rigorous, study measures that, any US or European study would have been proud of. So I don't think there are major limitations of this study. The event rates, the bleeding event rates were very similar to what we had expected. The ischemic event rates were somewhat lower, but with the almost identical ischemic event rates in the ticagrelor alone arm, you can be very confident that the worst amount of increased ischemia possible would probably not be much more than about 1%. So I do think the results are, pretty convincing, especially when taken in concert with all the other trials before.
Thank you so much, Dr. Stone. Thank you so much. So for more videos like this, please follow us in social media, YouTube and Twitter or X at FITsOnTheGo.